Okay folks, welcome to the last lecture in the cardiovascular system, circulation of the blood. One of the things we have to cover today in this session is control of the cardiac output, intrinsic control of stroke volume and extrinsic control of heart rate and contractility. In case you're not sure of the definitions, intrinsic means integral to itself, extrinsic is something that's outside stimulating the heart to contract. Also need to cover circulation of fluid between plasma, the interstitium and the lymph system. Way back when you did A-levels or similar, you will have covered the autonomic nervous system. What I need you to be aware of here is that your autonomic nervous system has two branches, the sympathetic and the parasympathetic. For the heart, stimulation of the sympathetic nerves increases the frequency of the heartbeat, so it makes your heart beat more rapidly. Circulating catecholamines, such as noradrenaline, remember it's also called norepinephrine in some textbooks, increases the cardiac muscle contractility, so how stretchy that heart muscle is, which increases the stroke volume, so how much blood the heart can pump out per heartbeat. This stimulates the reuptake of calcium by the sarcoplasmic reticulum, which means that more calcium is available to drive the next contraction of the heart. The heart is able to adapt to changes in the volume of blood in the ventricles at the end of diastole, so the end of the point where the heart has relaxed and the beginning of the next heartbeat. Remember from the last lecture where I covered Starling's law of the heart. This is a law that states that the end diastolic volume, so the amount of blood in the ventricles at the end of diastole, is controlled by the ventricular filling pressure, so the pressure of the blood coming into the ventricles, the central venous pressure, which is the pressure of the vessel, the blood coming into the atria of the heart through the veins, the vena cava, and the venous return, so how much blood is coming into the atria through the vessels. All three of these will affect the amount of blood that the heart is able to pump out at the end of its next heartbeat. By using Starling's law of the heart, we can see the effects of sympathetic stimulation on the heart muscle itself. So if you take the normal resting volume of our control individual, you'll see that the ventricular end diastolic volume is around about 120 millilitres of blood. When you move that across to look on the stroke volume axis, you'll see that equates to around about 40 to 50 millilitres in the stroke volume. If you move and increase that end diastolic volume for your control to say 300 millilitres, when you crack across to the stroke volume axis, you'll see that means the stroke volume has changed to around about 120 millilitres. If you then put in some sympathetic stimulation, for example through the sympathetic nerves to the heart, you'll find that for any given ventricular end diastolic volume, the stroke volume has increased. So if you look for the normal resting value, again being around about 120 millilitres end diastolic volume, you'll find the stroke volume has increased to about 80 millilitres of blood. Likewise, if you then follow it to our example before, where you've increased the end diastolic volume to around about 300 millilitres, you'll see a considerable increase in stroke volume of around about 180 millilitres of blood compared to the control of around about 120. This shows quite neatly how ventricular end diastolic volume, increasing that will increase the stroke volume. Reminding yourself of how the heart rate is regulated, having a look at this diagram, first thing I'll say is you do not need to learn the various blood vessels or the chambers in this point. You should already know the chambers of the heart. That's all I need you to take from this slide, of where the two nodes are and how the conduction pathway follows. So starting at number 1, you see in the right atrium we have the sinoatrial node. The sinoatrial node, remember, paces the atrial network of the heart, so conduction goes through the right atrium, across and into the left atrium. It then stimulates the atrioventricular node, which is shown at point 2. The atrioventricular node pulses the ventricular network, so it sends its signal of depolarization down the atrioventricular bundle, which is also called the AV bundle or the bundle of His. Through the septum, the bundle of His splits into left and right bundle branches, which pass through the septum of the heart, down to the apex, where they diverge off, going up into the left ventricle and the wall of the right ventricle. The small fibres coming off these bundle branches are the Purkinje fibres, and that's the final point of the conduction for this sinoatrial and AV node network. The atrial pacemaker cell, if you remember from the last lecture, naturally and spontaneously depolarise. They're termed autorhythmic fibres. You can stimulate sympathetic nerves, which will increase the rate of rise of the pacemaker potential. The pacemaker potential is the name given to this spontaneous depolarisation that brings the membrane potential up from its resting potential to the threshold value. In doing so, that increases the heart rate. You can also stimulate the parasympathetic nerves, the vagus nerve, which will have the opposite reaction. It will decrease the rate of rise of the pacemaker potential and therefore decrease the heart rate. Circulating catecholamines have the same effect as stimulation of the sympathetic nervous system and will increase the rate of rise of the pacemaker potential and thereby increasing the heart rate. Your brain ultimately controls what's happening with your heart. So you can have input from various cardiovascular centres, from the higher brain centres such as the cerebral cortex, the limbic system and the hypothalamus, and from sensory receptors, so proprioceptors which monitor movement, so found in the muscles, chemoreceptors which monitor your blood chemistry, and the baroreceptors, which we'll come on to in a moment, which monitor your blood pressure. Input from the higher brain centres into the cardiovascular centre in the medulla oblongata pass straight through the higher centres of the brain, whereas the sensory receptors liaise and link directly into the cardiovascular centre itself. The cardiovascular centre then has two potential outputs. The first is to the cardiac accelerator nerves, which are branches of the sympathetic system, and the output to the heart there is an increased rate of spontaneous depolarisation in the sinoatrial node and the AV node, which then results in an increased heart rate. It also increases the contractility of the atria and the ventricles directly, which again increases the stroke volume. Alternatively, the cardiovascular centre could send stimulation through the vagus nerve, also called the cranial nerve X, and the parasympathetic nervous system, which decreases the rate of spontaneous depolarisation in the sinoatrial and AV nodes, and therefore decreases the heart rate. At all times, the input and output from the cardiovascular centre is aiming to maintain the heart rate at a level where it's meeting the physiological needs of the body at a given time. This slide simply shows what's happening in terms of where the nerves actually come onto the heart. So, on the top left, this is the cardiovascular centre present in the medulla oblongata. First of all, you have the two blue nerves, which are inputs coming in from baroreceptors in the carotid sinus and the arch, the aorta. These are the two critical baroreceptors that you must know about in terms of the heart, as they're measuring the pressure going into the head and through the aortic arch itself into the body. These two nerve fibres come into the cardiovascular centre. You can also have information coming from the vagus nerve and the glossopharyngeal nerves. Do not worry about the names of the nerves. All I need you to know about here is that you have stimulation coming into the brain from the heart itself. Cardiovascular centre outputs can then come straight through the vagus nerve itself, through the parasympathetic system, and can actually create a synapse at the sinoatrial nodes and the AV nodes themselves. Likewise, information from the medulla oblongata can pass down through the spinal cord itself and out into the sympathetic trunk ganglions. These are the motor and efferent neurons shown in red. And the cardiac accelerator nerve, which is part of the sympathetic nervous system, doesn't just synapse with the sinoatrial and atrioventricular nodes, but it also forms synapses in a neuromuscular junction in the ventricular myocardium to increase the contractility of the myocardium in the ventricles itself. As the blood flows through the circulatory system from the aorta through to the capillaries and back into the heart through the vena cava, the blood pressure changes. So in this chart we have blood pressure going on the vertical axis versus the actual blood vessel it's going through on the horizontal. First of all, from the aorta and into the major arteries, you'll see that you have quite a clear pulsatile pressure from the systolic blood pressure down to the diastolic. And this is fairly constant throughout the arteries. As you move into the arterioles, the lumen narrows and the blood vessels themselves become significantly smaller, so the effect on the pressure is changing. As the blood passes through these vessels, it slows down and the blood pressure drops significantly. By the time you reach the capillaries, the blood is now no longer flowing in a particularly pulsatile fashion and the blood pressure is dropping even further. That's important for fluid exchange. The blood pressure at the arterial end is always higher than the blood pressure at the venous end of the capillaries. As the blood exits the capillary beds, enters the venules, finally the veins and the vena cava, you see a continuing drop in the blood pressure. By the time you're in the veins and the vena cava, the blood pressure in millimetres of mercury is extremely low. To give you an idea of what the blood vessels look like, this slide shows a capillary. So first of all, you have the lumen of the capillary, the endothelium showing the single layer of cells, and the basement membrane shown as the orange sheath. When you look at the light microscopy diagram, which has been stained, this is at 600 times magnification. See the connective tissue surrounding the capillary. The capillary epithelial cells are identified because their nuclei are stained dark blue and purple, and you can see the red blood cells passing through the capillary. So this shows just how small these capillaries are. They're one cell thick, so they're very, very delicate structures. You need the blood pressure to be low, otherwise they would damage the endothelial lining. In contrast to the capillaries, the arteries and veins are considerably more complicated structures. You do not need to worry about the terms of tunica interna, tunica media, or tunica externa here. They're simply relating to the location of that particular tissue, being either internal, in the middle, or the external of the vessels. Looking at the artery first on the left, you have the lumen in the middle with the endothelium lining. This is then surrounded by a basement membrane and an internal elastic lamina, which is an elastic layer of tissue which allows the blood vessel to have that stretchy elastic quality. In the middle of the tissue itself, you have a layer of smooth muscle. This is a very thick layer in the arteries. It gives the arteries a very muscular quality, so they're very strong, they're capable of contraction and relaxation, which enables you to change the blood pressure, particularly in the arterioles. Moving out from the smooth muscle, you then have an external elastic lamina, again which contributes to the arteries' inherent abilities to stretch and recoil. And finally you have the tunica externa, which is the outer covering tissue of the artery. It's an extremely tough layer to protect the artery. It's also fairly elastic and allows that recoil of the artery itself. Looking at the vein, we'll see almost the same levels of tissue. So the endothelium is the same, as is the basement membrane, but you'll note in the veins they lack the internal and external elastic laminas. They still have some smooth muscle in the veins, but not much. The veins are not capable of significant contraction or relaxation. As a result, the smooth muscle is there to enable them to function, but not to control the blood pressure. Inside the lumen of the veins, because the blood pressure is significantly lower by the time the blood reaches the veins, you don't have the same blood pressure forcing the blood through the blood vessel. In addition, as a rule, blood from the veins is moving from your feet towards your heart, so against gravity. As a result, there are valves along the length of the veins. So as the blood flows up through the vein, it can then fall back and fill in the valve and prevent backflow of blood right down. In addition to Starling's law of the heart, Starling has also developed laws and principles of fluid exchange. The two major points of this law is that fluid movement across the capillary wall is a passive process which is driven by pressure gradients across the wall. The capillary wall is a semi-permeable membrane across which plasma proteins can exert an osmotic pressure. What this basically means is as the blood pressure is higher at the arterial end than the venous end, there will be significant pressure gradient differences from one end of the capillary to the other. Meanwhile, plasma proteins will remain the same in the blood. Together, these two laws determine how plasma and other fluids can flow across the capillaries into the interstitium and back into the capillaries. This slide illustrates Starling's law of fluid exchange quite neatly. If you start at the left-hand side of the slide where the blood flow is coming from the arterial into the capillary, you'll see three pressures noted. There's the blood hydrostatic pressure of 35 millimeters of mercury, blood colloid osmotic pressure at 26 millimeters of mercury, and the interstitial fluid osmotic pressure, which is around about 1 millimeter of mercury. The BHP, blood hydrostatic pressure, is the amount of pressure forcing fluid out of the blood into the interstitium. In this situation, at the arterial end, the BHP is significantly higher than the colloid osmotic pressure, which tends to oppose fluid leaving the capillary. Blood colloid osmotic pressure is due to the fact that your plasma isn't just plasma and cells. It also contains proteins such as albumin and globulin, other hormones and other solutes. As a result, just as if you were trying to get fluid moving across a semi-permeable membrane from an area of high salt concentration to an area of low salt concentration, while the fluid is trying to move across, you have that concentration of solutes trying to prevent flow of water. That's the same in the blood. At this part of the blood, you also have the IFOP, which is the interstitial fluid osmotic pressure. This is the pressure exerted by dissolved solutes and proteins in the interstitium itself, which is tending to try and pull water out of the capillaries and into the interstitium. You'll note that the IFOP is small, it's only 1 millimeter of mercury. However, it is still useful. At the arterial end, you have 35 millimeters of mercury as your blood hydrostatic pressure, plus your interstitial fluid osmotic pressure of 1 millimeter of mercury, trying to pull fluid out of the capillaries, minus the BCOP, which is your blood colloid osmotic pressure, trying to oppose that blood coming out of the capillary. So in the end, you end up with 36 millimeters of mercury minus 26. So you have a net filtration pressure of around about 10 millimeters of mercury. This means at the arterial end, the forces are favouring fluid coming out of the capillary and into the interstitium. As you move through the capillary bed, the blood pressure will drop. So that means that the blood hydrostatic pressure has also dropped. At the venial end, the BHP is around about 16 millimeters of mercury. Your blood colloid osmotic pressure is still around about 26 millimeters of mercury because you haven't filtered out any of the solutes or the proteins such as globulin and albumin from the capillaries. Therefore, the BCOP is roughly constant. At this part of the capillary bed, you also now have interstitial fluid hydrostatic pressure, which is the amount of pressure trying to force fluid back into the capillary from the interstitium, which is actually about 0. So at this point, you have 16 millimeters of mercury minus 26 millimeters of mercury gives you round about minus 10 millimeters of mercury. In other words, net filtration pressure at this point is actually favouring the reabsorption of fluid into the capillary at the venous end. When you look at the total net filtration pressures, the net filtration at the arterial end of the capillaries is around about 20 litres a day and is calculated by blood hydrostatic pressure plus interstitial fluid osmotic pressure, so pressures promoting filtration, minus the net reabsorption at the venous end of the capillaries, which is around about 17 litres a day, and it's blood colloid osmotic pressure plus interstitial fluid hydrostatic pressure. So these are the pressures promoting reabsorption. In general, this means that you have an excess amount of fluid in the interstitium of around about 3 litres of fluid per day. That fluid then goes from the interstitial fluid into the lymphatic capillaries. It then moves into the lymphatic fluid itself, becomes lymph. It's returned to the blood plasma through the lymphatic system and back into the venous circulation. To break that previous slide down into simpler versions for you, these are showing the factors affecting the fluid exchange across the capillary wall. So from the diagram you can see you have 2 factors trying to pull fluid into the capillary and 2 factors trying to push fluid out of the capillary into the interstitium. So you have 2 hydrostatic pressures, the capillary hydrostatic pressure or PC and the interstitial hydrostatic pressure of Pi. Generally speaking, capillary hydrostatic pressure PC is significantly greater than Pi, so this tends to drive fluid to filter into the interstitium from the capillary. You then have the osmotic pressures. So you have plasma colloidal osmotic pressure, or ΠΠ, and interstitial colloidal osmotic pressure of ΠI. There's significantly more protein in the blood than the interstitium, so these factors tend to drive fluid into the blood. These two factors work side by side to control the fluid flow into and out of the capillary beds and into and out of the interstitium. So when you remember that you've got the hydrostatic pressure and the osmotic pressures working, your net pressure driving fluid out is going to be the difference in the hydrostatic pressures minus the difference in the osmotic pressures. The plasma osmotic pressure is quite high because of protein content, so ΠP is around about 25 millimeters of mercury. The interstitial osmotic pressure, however, is low, so ΠI is around about 3 millimeters of mercury. As a result, ΠP minus ΠI is 25 minus 3, so you end up with 22 millimeters of mercury driving the fluid into the capillary. That's assuming that the hydrostatic pressure in the capillary is significantly greater than that of the hydrostatic pressure in the interstitium. If we take that value and then put it into this diagram, we then have PC of around about 35 millimeters of mercury versus PI of about 1 millimeter of mercury, so significantly greater hydrostatic pressure in the capillary than the interstitium, so the difference is 34 millimeters of mercury. As a result of that, the net pressure forcing fluid out of the capillary is 34 millimeters of mercury minus 22 equals 12 millimeters of mercury, which is your pressure driving fluid out of the capillary into the interstitium. Meanwhile, at the venous end, the hydrostatic pressure in the capillary has dropped to about 15 millimeters of mercury. The hydrostatic pressure of the interstitium is still around about 1 millimeter of mercury, so the difference in the two is 14 millimeters of mercury. As a result, when we put in that value for the colloidal pressures before, the net pressure is 14 minus 22, so round about minus 8 millimeters of mercury. In other words, the pressures at this point are trying to drive fluid into the capillary. What you need to remember, if nothing else, is that the arterial end of the capillary, fluid tends to move out of the vessel. At the venous end, it tends to move in. If you remember that you have the cardiac muscle in the middle and you have two different circulations. You have the pulmonary circuit, where blood goes from the right side of the heart up into the pulmonary artery to be oxygenated, returns to the left side of the heart. You then have the systemic circuit, blood circulation, where oxygenated blood passes from the left ventricle through the aorta and round into the systemic blood capillaries before returning through the vena cava into the right side of the heart. Remembering from the previous slides, you have net pressures forcing fluid out of the capillary at the arterial end and back into the capillary at the venous end. There's a difference in the values of the fluid, so you end up with a net amount of fluid remaining in the tissues. This fluid that collects in the interstitial tissue has to go somewhere. If it isn't moved through the circulation and returned to the blood, you get excessive swelling. So this is returned to the circulation through the lymphatic system. The lymphatic system is shown on this diagram in green. So these diagrams show how the lymphatic capillaries actually in relationship with the capillaries of the blood and the tissue cells. So starting on the left, you can see that the lymphatic capillary is shown here in green, and it sits neatly in the capillary bed between the arterial and the venous end, in between all the tissue cells. Fluid from the interstitium between the cells enters the capillaries. Bearing in mind the lymphatic capillaries are blind-ended tubes and they're held in place by anchoring filaments. The additional fluid that is left in the interstitium passes into the lymphatic capillaries, where it's then carried to the lymphatic vessels through to the lymph nodes. Once the fluid has entered the lymphatic capillary, it's termed lymph. It's no longer termed tissue fluid. To give you an idea of the kind of volumes of fluid we're talking here, You filter around about 8 to 12 litres of fluid a day from the plasma into the interstitium. That additional fluid that isn't reabsorbed immediately into the plasma at the capillaries passes from the interstitium through to the lymph capillaries, through to the lymphatic vessels and into the lymph nodes. In effect, by virtue of going through the lymph nodes, your body is surveying the tissue's environment multiple times a day. So any factors, for example bacterial toxins, any signs of any infection or damage will be surveyed through the lymph nodes where it may trigger an immune reaction. Approximately 4 to 8 litres of fluid per day are reabsorbed from the lymph nodes back into the plasma. Meanwhile, in the pulmonary circulation, you have around about 4 litres per day of fluid is absorbed back into the lymph capillaries, through to the lymphatic vessels and back into the plasma. So that gives you a massive turnaround of around about 8 to 12 litres per day. All that changes if you have a significant inflammatory reaction. Remember that your net filtration pressure is the differences between the hydrostatic pressures minus the difference between the osmotic pressures. Vasodilation increases the diameter of the arterioles, which increases the blood flow into the capillary beds. That increases PC, so the hydrostatic pressure at the capillaries increases. Increased permeability of the capillary wall to proteins effectively reduces the difference between the osmotic pressures in the plasma and the interstitium. That means that you're changing the pressures that are trying to oppose fluid leaving the vessel. As a result of these two differences, you have an increase in PC and a significant reduction in the difference between pi-P and pi-I. That means the net filtration pressure will result in much increased fluid flux out of the vessel and accumulation in the tissue. This is termed edema, and in most situations is a perfectly normal response to inflammation. However, it can prove to be problematic if it becomes chronic. This is a situation here where this patient is suffering from a condition termed elephantiasis. This is swelling and enlargement of the tissue due to blockage of the lymph vessels. In this case, it's actually due to a parasitic infection with the parasite Leishmania. The condition of leishmaniasis means that parasites themselves block the vessels in the lymph fluid. As a result, they prevent the reabsorption of fluid from the interstitium into the lymph. So that additional 3 litres of fluid that's sitting in your tissues can now no longer be reabsorbed into the lymph system. As a result, it accumulates in the tissues, causing extensive swelling. You can see this is obviously a disabling condition. It's also a very painful condition. This is an extreme situation where the lymph vessels have been blocked. In most swelling conditions, it wouldn't be this extreme. In summary on this lecture then, you need to understand how we control cardiac output, so intrinsic and extrinsic control of heart rate and contractility. And you need to understand the circulation and the interplays of the fluid between the plasma, interstitium and the lymph. As always, if you need any help or any additional information, please contact me. Usually on my email address is the best bet.